Hi, my name is Dave Hong, and I'm the Deputy Chair in the Department of Investigational Therapeutics in the Division of Cancer Medicine here at MD Anderson Cancer Center in Houston, Texas. I want to welcome you to part one of the activity on RAS-targeted therapies for solid tumors. So RAS oncogene is one of the most prevalent oncogenic mutations that we know of in cancer. It was discovered over 40 years ago, and it hasn't been until recently that we've developed drugs to target this oncogenic mutation. RAS exists in an on and off state. RAS that initially is phosphorylated, but their GDP pocket is phosphorylated into GTP to activate it into KRAS GTP. And then downstream, it binds to other proteins such as RAF and PI3 kinase to drive tumorigenesis. The prevalence of RAS is, is likely to be close to 30 to 45% of all metastatic cancers. RAS exists in really three isoforms, H, N, and K. And within that, there are different codons or regions in which these mutant alleles occur. KRAS G12 or 12, the 12th codon is the most frequent, with others such as 13 and 61. Within those codons, there are specific mutations such as D, C, A, S, etc. And again, that prevalence or the distribution of those mutations depends to some extent on different tumor types. For example, in pancreatic cancer, which KRAS mutations occur in close to 95% of all pancreatic cancers, the most common mutant allele is KRAS G12D, in about 45% of those patients. The second most common mutation within that is G12V, and then G12R. In colorectal cancer, which again, about 30 to 45% of all colorectal cancers harbor a RAS mutation. The most common mutant allele is KRAS G12D, and then next is G12V, which is about 30-some percent, and then G12C. In non-small cell lung, the most common mutant allele is KRAS G12C, which occurs in about 46% of patients, and then G12D, and then G12V. Overall, in non-small cell lung cancer, KRAS only occurs in probably about 20-some percent of patients. RAS mutational testing is typical of all mutational testing that is ongoing currently. Many of our colleagues and many of you all out there in the community understand that next generation or NGS is really the standard of care for mutational testing. And RAS testing is no different than other testing for example, EGFR or other mutations such as PI3 kinase, or maybe even rare alterations such as NTRK. NGS really is that standard care, and to obtain that either through tissue or cfDNA is relevant. Now, both ideally, if possible, we would like to obtain mutational testing directly from the tissue, whether it's a biopsy or a resection. However, we understand that that can be oftentimes difficult when a new patient presents. Both of these tests, depending on the vendor, can often take 1 to 2 weeks to turn around and get the results back. So oftentimes, particularly in patients who are rapidly progressing, these tests are not readily available, and so standard care chemotherapy or other methods have to be implemented before testing is available. Both the RAS mutations will occur usually in most metastatic patients in the setting of other mutations. However, we believe that RAS probably is likely the major driver mutation beyond other rare alterations such as NTRK fusion or NRG fusion. RAS can exist with other mutations that we believe that can blunt the effect of, for example, KRAS G12C inhibitors, such as sotorasib and adagrasib, which are currently approved. There are data to suggest that certain mutations, such as KEAP1, CDKN2A, and perhaps STK11, may blunt the effect of KRAS G12C patients, particularly in non-small cell lung. So why is this? Why are we talking all about RAS and RAS testing? Well, we believe that in the next 2 to 3 years, targeting RAS will truly be transformed by these new emerging therapies. As I've already shared, there are now 2 therapies that target KRAS G12C, sotorasib and adagrasib in second-line non-small cell lung cancer. Also, adagrasib plus cetuximab has been approved in KRAS G12C colorectal cancer patients in the second-line setting. And so that is just the tip of the iceberg of what will be emerging in the next several years. My colleagues, after my initial presentation, will go into detail of the emerging therapies that will target other KRAS mutant alleles such as G12D and perhaps all of KRAS. But beyond just the small molecules, we believe that there will be other therapies such as PROTAC inhibitors and also even immunotherapies such as engineered T cells that may be able to target all of RAS. And so in the next decade, we believe that RAS therapy will be truly transformative for close to 30 to 45% of all of these metastatic cancer patients in the near future. So I do think that the development of RAS therapeutics will really transform oncology, almost similarly, more so similar to what we saw with checkpoint inhibitors, where, for example, nivolumab, especially pembrolizumab and ipilimumab, have really transformed cancers, not just in melanoma, but now profoundly in lung and other tumor types, such as MSI, colorectal, etc. I think the prevalence of RAS mutations that exist across all different tumor types may truly be able to transform all these different tumor types. I think the challenges remain twofold. One is testing is still, although increasingly widespread, it's not it's not like an automatic reaction, especially in the frontline setting. For example, in pancreatic cancer, we don't usually get mutational testing, but I do believe that if these drugs are improved, particularly the pan-RAS inhibitors or the KRAS G12D inhibitors, which will hopefully have a profound effect on pancreatic cancer, this testing has to be done upfront and as quickly and soon as possible. Theoretically, since these drugs may be able to even benefit patients who have not received any chemotherapy. These are similar challenges that we've had with other therapies that have now transformed oncology.
Hello, everyone. My name is Dr. Eileen O'Reilly. I'm a medical oncologist from Memorial Sloan Kettering in New York, and delighted to be here today to welcome you to this second part of the activity focused on RAS-targeted therapies for solid tumors. And we're going to be discussing where we are in pancreas cancer with respect to RAS targeting. To get us started, one of the topics we're going to address is what are the current challenges for pancreas cancer and how do we treat this disease today? And just by way of introduction, to mention that most people will present with metastatic disease, and in that setting, treatment is non-curative in intent, and the mainstays of treatment are chemotherapy-based, And there are many reasons put forth as to why pancreas cancer is so challenging. And one of them is the topic of discussion is the fact that it's a RAS-driven disease and it's has inherent resistance to chemotherapy. It's an immune suppressed environment, and there, are lots of putative explanations otherwise that this disease is, highly genetically complex and immunologically suppressed, and that limits some of the effectiveness of our current therapies. So, moving to the next part of the discussion is what is the role of RAS mutations in pancreas cancer? And RAS mutations are near ubiquitous in this disease. The harder you look, the more you'll find, in that about 95% of people with pancreas cancer will have a KRAS mutation. And it comes in several different versions with a single amino acid substitution differentiating these mutations. But KRAS G12D, G12V, and G12R are the most common mutations, about 40%, about 30%, and about 15% respectively. And they, RAS mutations, switch on a signaling pathway that results in sort of downstream activation, and it results in growth, metastasis, it results in immune suppression, and contributes to the inherent resistance to treatment in this disease. Going back to the topic of how we test for these mutations, and that's a really key part to be aware. For every individual with this disease, it's recommended that they have germline testing, looking for any hereditary predisposition genes, but also looking for targeted opportunities. And we also now want to incorporate, at the time of diagnosis, RAS testing and testing for other oncogenic drivers when there's no RAS mutation present. So, two tools are somatic tumor based testing. That takes time, increasingly utilizing ctDNA testing in pancreas cancer, acknowledging that there can be limitations to ctDNA testing depending on the disease volume, and noting that relative to other malignancies, that there's low shedding in pancreas cancer. So an important question is, what might be critical to integrating RAS therapeutics to the treatment in pancreas cancer? I think is several considerations, recognizing the importance of RAS in this disease, starting to test for RAS and doing this testing early. And if you think about this, pan-RAS inhibitors, arguably, you may not need to know RAS mutation status in pancreas cancer because theoretically these drugs target the full spectrum. However, if one is looking at a allele specific targeted approach, and maybe perhaps for some people greater value in terms of less toxicity, perhaps, and this is a little speculative today, as we don't know the full comparison both in terms of efficacy, in terms of safety and durability and depth of response. But knowing this information early is going to allow those choices. And thinking about this, I would say at the time of diagnosis, and that's what we try to do in practice, is every single person that we meet today, it's both germline, somatic, and ctDNA testing. And I'll just make the point that tissue acquisition in pancreas cancer can be very challenging. Sometimes we're working from very small biopsies. Sometimes it takes several attempts to actually confirm a diagnosis, and all of this is time. So a complementary tool being this circulating DNA, where the yield is greatest in metastatic disease, where we see bulky disease, not always as lucky in early stage disease. So having ideally in an ideal situation, option to do both germline, ctDNA, and tissue-based testing, I think, gives the greatest yield and understanding what that profile is for a given person. So moving to the targeting of KRAS and having been in drug development for a while in this disease, this is a very exciting space that we're now seeing potentially targetable opportunities in pancreas cancer. And, without overstating it, it may be that pancreas cancer will become one of the most targetable diseases because of the frequency of the driver mutation in this disease. And there's a lot happened in the last few years. If we start with the KRAS G12C story, that was the proof of principle that targeting RAS in pancreas cancer has a precedent. So 1% of people with KRAS G12C mutations, starting initially with sotorasib, adagrasib, and more recently, divarasib, olomorasib, and other just 12C inhibitors. But bottom line, in previously treated pancreas cancer, in most of these studies, they were single arm, non randomized. We saw response rates up to 20% and more, and showing a median survivals of 6 months and beyond in a targeted setting in previously treated disease. And if you reference that to what chemotherapy does in that setting, it's a few short months of response and median survival being less than 6 months for most patients. So suggesting even in this small subset that there's value to a single targeted drug against G12C. So more recently, we've seen data using pan-RAS inhibitors and allele-specific inhibitors in pancreas cancer. And to explain the difference, the allele-specific or mutant-specific inhibitors target a narrow spectrum. So, for example, targeting G12D specifically, and pan-RAS targets all of the common RAS mutations, including RAS wild type and including, not so relevant in pancreas cancer, but targeting NRAS and HRAS, which is relevant in other diseases. So looking specifically at the pan-RAS inhibitors in pancreas cancer, in previously treated disease, once more we see notable response rates of 20, even approaching 30%, and progression-free survival of between 6, 7, and 8 months, and early signals of survival in this population even approaching over a year, which is really, really interesting. And that has led with the pan-RAS inhibitor RMC-6236, which has a unique mechanism. It binds cyclophilin, it forms a tricomplex and inhibits other binding to RAS, and may be part of the mechanism for this high signal that we see. And that's now moving to a phase 3 setting in a second line context in pancreas cancer compared directly to chemotherapy. So that's underway. Looking at the allele-specific inhibitors, other drugs include RMC 9805 targeting G12D. And once more, we see a high response rate, almost 30%, and high disease control rates. These drugs may have a more favorable toxicity profile relative to the pan-RAS inhibitors, perhaps less rash and less diarrhea. And we'll see how this evolves in the clinic. And other drugs that are being evaluated include PROTACs, so different mechanism targeting the protein as opposed to the gene. And we also have seen some data suggesting activity in this disease, and there's many other agents in early phase 1 dose and safety finding development in pancreas cancer.
Hello, my name is Dr. Rebecca Heist. I'm a medical oncologist at Mass General Cancer Center. Welcome to part 3 of this activity on RAS-targeted therapies for solid tumors, in which we'll focus on non-small cell lung cancer. Testing for RAS mutations is incredibly important We know that RAS mutations are very common in non-small cell lung cancer. They make up about 30% of the mutations that we see when we look at the mutational profile in non-small cell lung cancer in general. And until very recently, RAS and KRAS mutations were considered undruggable. It was really many, many years of drug development where there were real challenges in finding the right ways to be able to target these mutations. And then over the last several years, we've seen actually a great deal of progress in this arena. There's been approval of 2 KRAS G12C directed targeted therapies. Both sotorasib and adagrasib are approved for KRAS G12C mutated lung cancer. And that's been a huge advance. It has really transformed our ability to treat patients with KRAS mutations and taken this target that we thought for decades was not going to be druggable and turned it into a druggable target. So this is a great advance for lung cancer treatment in general. And there are many, many more therapies in the pipeline with more G12C inhibitors being developed, but also more KRAS targets other than G12C that are in development as well. So when you think about diagnosing somebody with lung cancer, and you think about what's all the information that I need to know at diagnosis in order to be able to develop the best treatment plan, we know that there's an array of biomarkers that we need. We need the histology, we need the PD-L1 status, we need a comprehensive next generation sequencing, broad molecular target mutation panel. And there are a host of mutations that we need to know about for our lung cancer patients in order to develop the best treatment plan for them. And KRAS is one of them. One of the challenges, of course, is it's important to test and know at the outset what a mutational profile of a patient's tumor is, because some of these G12C inhibitors like sotorasib and adagrasib we reserve really for use in the second line and beyond setting. Keeping track of that information is really important. I would hate to be in a situation where after months and months of treatment on first line treatment, then all of a sudden that piece of information that's so critical to know what the next best line of treatment is going to be is hidden somewhere on a chart or not retrieved or kind of forgotten about. And so making sure that that data that's usually gotten in that first line setting is kept front and center in people's minds so that these targeted therapies, when they become options down the line in terms of the lines of therapy, are really kind of picked up on and used is really, really very, very important. Yeah, so the clinical impact of the current G12C inhibitors is huge. We did not used to think that G12C or KRAS in general was a druggable target. So the fact that we have KRAS G12C specific drugs is actually a huge improvement. So we know that sotorasib and adagrasib are approved for use in lung cancer with KRAS G12C mutations in the second line and beyond. And this is based on data where we saw response rates ranging from 37% to 43% in various phase 2 studies. And this is a huge improvement with the ability to now target KRAS G12C, whereas we never had that before. We know when we compare with second-line chemotherapy, for example, docetaxel, and there have been studies comparing both sotorasib against docetaxel and adagrasib against docetaxel, then indeed we do see higher response rates with these targeted G12C inhibitors compared to a standard second-line chemotherapy. The median PFS is improved. We haven't seen big data regarding overall survival yet. But I would say that in general, when we think about these data, we think, great, we can drug this target, but the response rates aren't quite as high as what we are used to seeing with some other targets like EGFR and ALK, for example. And the PFS benefit isn't quite as prolonged as we see for some of these other targets. And so there's a lot of room for improvement, and there's a lot of work being done to see, can we develop better KRAS G12C inhibitors? We think that we can, and there's a lot of work being done in this setting. Many drugs are being developed in this setting, and there are other mechanisms of action that are being pursued as well. So, for example, RMC-6291 has response rates that have been reported anywhere from 43 to 50%. This is in relatively small numbers of people, but I think what's interesting about this particular drug is that it uses a different mechanism of action compared to the current approved G12C inhibitors. This drug in particular binds to the on state of KRAS, and I think that different mechanism of action is very interesting to pursue and think about. And there are other potent G12C inhibitors that are being investigated that use a similar mechanism of action to the currently approved drugs, but perhaps are more selective or potent. And some of the response data that we see are slightly higher than what we've seen with the current available drugs. And so in general, many next generation KRAS inhibitors that are in development and being actively studied. I think the numbers are still relatively small, and the jury's still out about whether this will be kind of a really big leap forward in terms of treatment in this setting. But I think there's a lot of interest here and a lot of activity, because it is definitely a huge advance that we now have KRAS G12C specific targeted therapies, but we want to do better, and we want to have better outcomes for our patients. And so there's a lot of development in this space. We've talked a lot about KRAS G12C, but as you know, KRAS mutations, which occur in lung cancer and other cancers, really have a host of different mutations, not just G12C. And so being able to target those other mutations is really important. It's also really important to know about those mutations so that you know when the patient that you are treating has something like a G12V or a G12D, for example, because those are important to know. There are clinical trials that might be relevant that could be really of particular interest to that patient. So outside of G12C, for example, there are multiple KRAS G12D inhibitors that are in development. These are all in clinical trials. There is not one approved yet, but we've seen some interesting signals of activity with some of these KRAS G12D specific drugs. And so I think that's an arena where over the next several years, we will likely see some activity with some of these G12D inhibitors being able to move into the clinic. And then, of course, there are other kind of pan-KRAS inhibitors that are being studied as well. One example is RMC-6236. This is a KRAS inhibitor that binds to the on state. And this has had data that's been presented at various international meetings. And KRAS on-state inhibition with a multi-RAS inhibitor actually has shown good tolerability. The most common AEs that we're seeing with this particular drug included rash and GI-related toxicities, but most of these were grade 1 and 2. There was not a high rate of grade 3 toxicity. And it's shown really interesting anti-tumor activity in lung cancer patients treated in the second-line setting and beyond who had KRAS mutations. The response rate that was reported was 38%, the median PFS of 9.8 months. I think this kind of opens our eyes to the fact that beyond KRAS G12C, there are other KRAS mutations that we should be paying attention to, that we should be testing for and making note of. And there are next-generation drugs being developed in that setting that are really interesting. And I think it'll be very interesting to see more data as it gets reported over the next 1 to 2 years ahead. One of the key takeaways to walk away with is, one, make sure you're testing broadly and make sure that you're paying attention to that KRAS mutation status. And I think it's really important to note when people have a KRAS mutation, and specifically what type of KRAS mutation it is. There are approved KRAS G12C inhibitors. It's really important to know about that. And although outside of KRAS G12C right now, there are not approved inhibitors, I think with the clinical trials that we're seeing and the drug development that's happening, it's very possible that over the next couple of years, we're going to see more drugs enter into this space. And so knowing in your patients what their mutational profile is for the tumor, if they have a KRAS mutation, what it is really important.